I kindly call upon Dr. Vijay Kumar, immediate past president, to the stage, please. In the month of March, we did many activities. We'll start up with the Cme hospital. We had nearly around 3 patients admitted, and Dr. Satish was doing a very wonderful job there. We did nearly around 15 events. To start with, in the month of March, we started with National Safety Day, and on the same day we also celebrated World Obesity Day. And on March 8th we had National No Smoking Day, and on the same day International Women's Day was also celebrated. On March 9th World Kidney Day was celebrated. March 17th, 2 events, National Vaccine Day and World Sleep Day was celebrated. And on 18th, World Glaucoma Week was celebrated. And on 19th, again 2 events was there. One was Village Adoption Program, and other one was State Council meeting. And on 20th, World Oral Health Day was celebrated. And on 24th, World TB Day was celebrated. And on 26th, two events were there. One was Epilepsy Awareness Day, and monthly meeting was also on the same day. And on March 30th, we had World Bipolar Day. It was also celebrated. This was the National Safety Day, which was celebrated at Nanda College, College of Nursing. Nearly around 130 students participated in the event. And this was National No Smoking Day. A rally was conducted which was inaugurated by our Erode DSP sir, and it was preceded in front with Sudha Hospital. The rally started from VOC Park, and it was up to Sudha Cancer Hospital. After the rally, there was a small awareness talk given by our Dr. Sugishwaran of Sudha Cancer Center. This was National Women's Day, celebrated at many places. On behalf of Women's Doctors Wing Chairman Dr. Narmada participated and distributed gifts to 10th and 12th toppers. This was National Women's Day, celebrated along with Indian Dental Association. International Women's Day, celebrated at CAR 24 Hospital. A talk was given by Dr. Karupanan sir. And this is the Women's Day celebration at Abhirami Kidney Care Hospital. This was at Veena Hospital. This was at Ashwin Hospital, Darshan Hospital, VSM Hospital, and Sri Raghavendra Eye Hospital. This was at Erode Trust Hospital. This was the World Kidney Day, celebrated at 4 places. Initially, we started a rally from RANM Hospital, from IMA Hall to RANM Hospital. Nearly around 200 people participated in the rally. Dr. Nagendran sir was there. This was the World Kidney Day. A small camp was done at Abhirami, Kalyani Kidney Care Hospital, and a small CME was done at Sendil Multi-Specialty Hospital on the same day. And rally was conducted from Erode GH to Abhirami Kidney Care, and nearly around 200 students participated in the event. This was also followed by a short small CME and an awareness talk. This was a National Vaccine Day. Dr. Vasant from Erode IMA participated and gave vaccines to children. This was a World Sleep Day. This was celebrated at with the help of Women's Doctors Wing Chairman Dr. Saranya and Dr. Uma Shankar. Staff nurses were educated about how to conduct sleep study, and few patients were educated about the necessity of quality sleep. This was the World Glaucoma Week, which was done at KSI Hospital by Dr. Jayanthan. State Council meeting was last month was conducted at Madurai. Nearly around 10 to 12 members participated from Erode IME branch. In continuation of the village adoption program by our president, from Erode IME we adopted another village, and Dr. Janet Madam, Dr. Shivanandan, Dr. Naveen Kumar and Dr. Saravana Kumar participated, and nearly around 89 patients were treated. On World Health Day, with the help of Indian Dental Wing member Dr. Surendran, nearly around 15 patients was treated on the particular day, and a small talk was given. And on the same day, on the World Health Program, a small talk was given by immediate President, Dental President Dr. Uma Shankar at CAR 24 Hospital. This was the World TB Day celebrated at Erode Trust Hospital by Dr. Sharanya. Nearly around 40 members participated, and the necessity of anti-tuberculous drugs and how to take care of TB patients were treated. A talk was given. This was the monthly CME that was done on the last month, and nearly 160 members participated, and it was Dr. Neminathan and Dr. Raghunandan from Chennai participated. Elaborate talk was given. Many members appreciated the talk. Epilepsy awareness program was done on 26th March at Modakurchi. Nearly 60 people participated. That was a free camp with the help of BMT. BMT, it's a Benchmark Medical Trust. This was World Bipolar Day celebrated at Erode GH by with the help of Dr. Jayakumar and team. On the same day, the World Bipolar Day, awareness talk was given at CAR 24 Hospital. There was a crisis event that was happened in a private hospital which was effectively managed, and luckily there was no undue happenings happened on the day. Regarding blood camp, Dr. Chitra Madam did a wonderful job. Nearly around 284 bags of blood was collected from nearly 6 camps was conducted, and 284 packs of blood was collected. Thank you. And coming to this month, we have invited 2 speakers. One, Dr. Ram from Lotus Hospital, and Dr. Ajita from Coimbatore. Dr. Ram will be talking about emergencies in general practice, and Madam will be talking about role of bone marrow transplant in non-malignant conditions. And I request all the members to kindly submit the membership updation form. Only out of 1,200 members of our data list, we have received near almost around 180 only. Without that these list, we cannot able to go for society's registration. That is one big event that is pending, and also our upcoming election is there, so we need the datas of the members for sending all the ballot forms. I kindly request all the members to submit the updation forms. Thank you. Now I will kindly call upon Dr. Ajita.
Slideshow. Light off பண்ணிடு. So good evening to all. I thank IME Erode for giving me the opportunity to speak here. So Erode is not a new place to me, but this is the first time I'm coming and addressing a gathering of doctors here. So I wanted to keep the topic very simple, though it sounds very complex. Basically, it is about bone marrow transplant, how we do it, and what are the indications. So generally, when we think of bone marrow transplant, we think it is related to cancer, but there are a lot of benign conditions, especially in children, where bone marrow transplant is the standard of care for cure. So we have to simplify life as well as subject for our ease. So when we think of ATP production, it is very complex, glycolysis. But I remember that glucose gives rise to ATP. So similarly, we have to just keep the things simple for understanding bone marrow transplant. So I put a topic as HSCT. Now HSCT stands for hematopoietic stem cell transplant. Previously we used to call it bone marrow transplant because we used to harvest the bone marrow from the posterior superior iliac spine. Now we can get the stem cells from the peripheral blood itself. So that is why it is called hematopoietic stem cell transplant. So what is the difference between other stem cells and hematopoietic stem cells? Now we know that embryonic stem cells, there used to be a lot of research, then it was banned because it was considered unethical. Hematopoietic stem cells are multipotent stem cells because they can give rise to red cells, white cells, platelets, whereas embryonic stem cells are totipotent cells. They can give rise to any cell in the body. So hematopoietic stem cell is a multipotent stem cell which gives rise to common lymphoid stem cell, common myeloid precursor, which gives rise to all the cell lineages of the blood. So we can think this setup as a seed and soil. So you have a microvasculature, you have a soil there in the bone marrow, and the hematopoietic stem cells are the seeds. So there is a complex environment there. There are a lot of interactions happening there for the stem cell to function normally. So how did it all start? So we all know during World War II, there was atom bomb, and then there was bone marrow failure secondary to that. So a group of scientists wanted to know how we can make the patients recover. So what they did was they infused stem cells from a healthy person. So not all was success, but certain conditions it led to success, and the bone marrow failure patients recovered. So the person who pioneered this was Dr. Donnelly Thomas, and he got the Nobel Prize along with Dr. Joe Murray, who is a renal transplanter. So why do we do bone marrow transplant? Now we know whenever there is an organ failure like a renal or a liver transplant, we give a healthy organ so that it starts functioning. The similar thing applies to bone marrow transplant also. Whenever there is a pathology in the bone marrow, it can be a failure of production or it can be an abnormal production. So you eliminate the bone marrow of the person and then you give healthy stem cells so that it will give rise to new blood production or the new cell lineages. So before we do that, we cannot simply infuse. We have to prepare the patient for receiving the stem cells. So there are two types of transplant based on who is the donor. Now if you take the patient's own stem cells and you give it back to the patient, it is called an autologous transplant. When you collect a stem cell from some other person and give it to the patient, it is called an allogenic transplant. So why do we need to give autologous transplant if the patient already has the disease? So basically this is mainly indicated for cancers. So whenever we have cancer, it is a mass, so we have weapons of mass destruction, that is, we have chemotherapy. But chemotherapy, the issue is that you have a dose limiting toxicity, so you cannot give beyond a certain dose because the bone marrow will fail. So what we do in autologous transplant is that we give supratherapeutic doses of chemotherapy. It is called high dose chemotherapy, but the patient will have bone marrow failure secondary to that. So for the patient to recover from bone marrow failure, we give the stem cells. So it is basically stem cell rescue for high dose chemotherapy. So autologous transplant is indicated in a lot of lymphomas, either upfront or in relapse, in solid tumors like neuroblastoma, which is the most common indication in children, medulloblastoma, Ewing sarcoma. Most common indication in adult for autologous transplant is multiple myeloma. And even in autoimmune disorders like juvenile rheumatoid arthritis, systemic sclerosis, autologous transplant helps because it resets the immune system so that the autoimmunity is reversed. So you give high dose chemotherapy. So we give high dose chemotherapy, that is bone marrow failure, and we give the stem cells. So before we give the stem cells, we give the high dose chemotherapy. Now coming to allogenic transplant. So whenever we have a pathology which is inherited, which is genetic, you cannot give back the patient's own stem cells because the stem cells also carry the same genetic defect. So what we have to do is we have to give a stem cell which is healthy. So that is why we have to take it from some other source. So what are the conditions which we generally do a allogenic bone marrow transplant? So one is whenever there is a bone marrow failure. So the problem is here. In the stem cell level, there is failure of production of all these cell lines. So you give a new stem cell. Now this bone marrow failure can be inherited or acquired bone marrow failure. So acquired bone marrow failure is called aplastic anemia. Another condition is commonly leukemias. So in leukemias, we cannot do an autologous transplant because there is some amount of residual leukemic cells. So you have to give someone else's stem cells. You have to change the immunity so that the donor's immunity attacks the recipient's leukemia cells. So that is why in leukemias, you have to do an allogenic transplant only, unlike other solid tumors. So in leukemias, the problem can be here, or anywhere in between. So mostly for acute leukemias, the problem is in the lymphoid progenitor. And for myeloid leukemias, it is the myeloid progenitor. So now comes, so this is cancers, this is benign condition. There are a lot other benign conditions which are quite rare, in which transplant is curative. One rare group is immunodeficiency disorders, where there is either T cell or combined immunodeficiency by birth. So these children will not have immune system. So you are supposed to give the new immune system from the stem cells. So most of the indications will be disorders in the T cells. Next, the most commonly performed transplant in children will be for thalassemias. So whenever you have an abnormal RBC production, because there is abnormal hemoglobin synthesis which happens in thalassemia and sickle cell anemia. So you give a stem cell which lacks the genetic defect, that will give rise to the normal erythrocytes and normal hemoglobin production. Other disorders like platelet disorders and neutropenic disorders are rare indications. One huge group of disorders where bone marrow transplant can help is inherited metabolic disorders like storage disorders. So pediatricians would be aware that we have a lot of storage disorders. We have mucopolysaccharidosis, we have Niemann-Pick disease, Gaucher disease, and we have leukodystrophies which can be cured by bone marrow transplant. Now everyone might have a question of how it works, how bone marrow transplant works in some storage disorder. So basically in storage disorder, the problem is that the macrophages are not able to produce the enzymes responsible for degrading some products. So these macrophages are actually derivatives of your myeloid precursors. So when you give a proper stem cell, it will lead to production of normal macrophages which will start producing the normal enzymes, and these enzymes will clear the storage product. So that is how bone marrow transplant helps in storage disorders. So I come from a background of agriculture family, and majority of the patients come from areas in and around here. So I explain steps of transplant with agriculture background. So first is patient selection. The patient should be in a good general condition, performance status, and the donor selection. So this can be compared to seed and the soil. So seed should be the donor and soil is the patient. So that should be good first. Next is conditioning. So like I said, whenever you give stem cells like that, the recipient tends to reject the stem cells. So our immunity always knows what is self and what is foreign. So you have to suppress the immunity of the recipient, number one, and you have to make some space in the marrow. So that is called myeloablation. So these two purposes are achieved by giving chemotherapy. This is called conditioning. It is just like plowing the land. Next we infuse the stem cells, which is sowing. Next, we wait for the stem cells to start producing new cells. This will take at least 2 weeks. So the patient will be neutropenic for 2 weeks at least. And then we have a period where we wait for the stem cells to come up, and there can be problems because these stem cells start functioning. So that I will discuss later. So that is called either rejection or graft versus host disease. Rejection means the patient doesn't accept the stem cells at all. It is a nightmare because you again have to do an immediate bone marrow transplant. That is like a barren land. Graft versus host disease is when the patient, the donor's immunity, that is the new immunity from the donor, starts attacking the recipient body. So that is graft versus host disease. So these two are exactly the opposite. Then post-transplant follow-up and monitoring for infections. So before that, not everyone can be a donor. So just like blood group, we need to have something called as a HLA match in bone marrow transplant. So HLA is like a molecular fingerprint. It is unique to each individual. It is the human leukocyte antigen system which tells us which is foreign and which is self. So whenever we have an identical HLA system, the body thinks that the recipient stem cells are like our own, and the recipient stem cells also thinks that the donor stem cells also thinks that the recipient body is its own. So we have one set of HLA antigens inherited from mother and one set from the father. So it is just like your Mendelian autosomal recessive inheritance. So when suppose this is the patient, there is a 1 in 4 probability or a 25% chance that one of the siblings can be a match because they have the same inherited genes from both the parents of the HLA. So that is why the best donor would be a matched sibling. If there is no matched sibling, what we can do is we can find an unrelated donor who is completely matched. Now HLA, the major HLA, we look at 5 locus. So 5 locus in 2 genes, both paternal maternal genes, means that we look at 10 loci for matching. So completely matched donor who is someone matched 10 out of 10 in all these loci. So how do we choose a donor? So first we do the HLA typing of the patient and the sibling. So that can be done by a buccal swab or a blood test. So if it is going to be an identical twin, it is called a syngenic transplant. So similar genes, same genes. And if the family member is matched, it is called a match-related donor transplant. And if it is an unrelated donor, because in India we have closed marriages, there is a possibility that an unrelated person can still have a 10/10 match. So they are called unrelated donor. And if none of the donors are available, suppose if you don't have a sibling or an unrelated donor, then what we can do is, recently we have a development called haploidentical transplant. That is, the parents are actually half matched because they are giving their HLA genes to the children. Now the parents can be used despite being a half matched, so using certain techniques. So that is called as haploidentical transplant. This has transformed transplant because in the worst case scenario, we have one of the parents who can be taken up as the donor. So this is the flow chart. So if you have a HLA matched sibling, you use the sibling as a donor. So there is a 25% chance. If not, when we do a HLA test, we have a computer-based registry. So in that, we can get the result in 2 days for unrelated donor search. So if that, in India, the largest unrelated donor registry is called DA3. So usually we give the report to DA3, they give the result in 2 days. If we don't have an unrelated donor, then we can consider alternate donor like half-matched haploidentical transplant. So like I said, conditioning, before we give the stem cells, we have to condition the recipient. So one is to suppress the immunity of the recipient so that he will accept the stem cells. One is to create space in the marrow. And for this we give usually chemotherapy, sometimes a low dose of radiation also. So coming to the stem cell source. Now we were talking about stem cells. So how do we get it? So the most commonly preferred method or used method is peripheral blood stem cells. So this is just like doing a pheresis. So just like doing a plasma pheresis, but instead of removing the plasma, we remove the stem cells. So we have a pheresis machine here. So we have a central line catheter. So from the patient, the blood goes into the machine. By means of centrifugation, the machine separates the stem cells. By means of optical density, we can tune the machine to say which is stem cells. So that is collected in a bag. The rest of the blood goes back to the patient. So this is peripheral blood stem cell collection. The historical method is bone marrow, but still we prefer in certain conditions bone marrow to be a source of stem cells. So this is just like doing a bone marrow aspiration, but this requires general anesthesia. This is a simple procedure, no sedation is required. Here you require GA, and from both the posterior superior iliac spine generally two doctors, they aspirate the bone marrow and they collect it in the bag, blood bag. Now everyone would have been aware of umbilical cord blood cells. So what we do is, as soon as the newborn is born, we collect the umbilical cord blood and we store it, we cryopreserve it. So this is no longer preferred means of stem cells in bone marrow transplant, because when we use these sources, generally the stem cells start functioning in 2 weeks. That is, we call engraftment. So the new white cells start coming up in 2 weeks. Whereas in umbilical cord blood, if we use, it will take up to 3 weeks. So in our country, an extra 1 week period of neutropenia is going to be dangerous for the patient, because we have a lot of multi-drug resistant organisms. And one more thing is, the dose and the preservation quality is not adequate in our setup. That is why almost no one is doing a umbilical cord blood transplant. If at all anyone is using this as a source, generally they use it as a top up along with other two sources. So they use a bone marrow or a peripheral blood and they use it as a top up. So this is the procedure. From the donor we collected by apheresis machine, and when infusing it to the patient, it is just like any other blood transfusion. So just there should be a central line in place. So we infuse just like any other blood product. There is no surgery involved to the recipient. So why is it carried out in special place called bone marrow transplant unit? So we have a bone marrow transplant unit, which is a positive pressure room. We have a HEPA filter. So why do we need to do it in a certain protected conditions? This is because we have a prolonged period of neutropenia, almost 2 weeks after we have given the chemotherapy. So during this period, the patient essentially has no immunity and healing is poor. And the patient will have central line, he will have mucositis. So the white cell count will be almost 0 or 100 for a period of at least 2 to 3 weeks. So this period is very important, and that is why we prefer to do it in bone marrow transplant units. So rejection is when the recipient doesn't accept the stem cells of the donor. So this is a nightmare, because the stem cells will never recover. We have given chemotherapy, high dose chemotherapy. So immediately we have to proceed with another stem cell collection and infusion. So this is a very, very dangerous situation. Fortunately, it is quite rare. More commonly, what we see post-transplant is something called as graft versus host disease. This may be something a little complicated to understand, but it's actually quite easy. So in solid organ transplant, so what happens in solid organ transplant is that the recipient has the immune system. So the recipient's immune system attacks the transplanted organ. So the danger there is rejection. Whereas in a bone marrow transplant, once the stem cell starts functioning, the new white cells, the immunity is from the donor. So post-transplant, the entire blood is going to be from the donor. Even the blood group may change if there is a blood group mismatch. So what happens is, the donor-derived immune cells, they think that the recipient organs are foreign and they start attacking the recipient organs. So this is called graft versus host disease. So the reverse happens. So this is very, very unique to bone marrow transplant, as we are resetting the immune system. So we can think something similar to a police and a thief. So our immune system is the police. In solid organ transplant, this is the recipient's police which attacks the donor kidney. Whereas in bone marrow transplant, it is the donor immune system which is actually going to function, and that attacks the recipient organs. So this graft versus host disease doesn't attack all organs uniformly. The more rapidly dividing cells are affected. So your oral cavity, your skin, liver as well as gut, these are the organs affected. So there can be something called as an acute as well as a chronic GVHD. Acute GVHD is like any other inflammatory response. There will be peeling of skin, peeling of mucosa, there can be peeling of gut, diarrhea, skin rashes, etc. Chronic GVHD is something similar to a chronic autoimmune disease like scleroderma. So there will be all sclerosis and scarring. So this is an outline to bone marrow transplant. And so a few words about umbilical cord blood banking. So there has been a consensus statement given by the Indian Academy of Pediatrics, which has been published regarding when and how to store umbilical cord blood cells. So there have been many questions posed to me whether I should preserve my daughter or son's umbilical cord blood cells. So actually, umbilical cord blood is a very rich source of stem cells. These stem cells are all naive. They have not been exposed to any antigens at all. So like I said, the HLA 10/10 match may not apply to umbilical stem cells, because umbilical stem cells you can use even a lesser match. So theoretically it seems appealing, but why don't we use it? I said earlier, because cell dose may not be adequate and there is a prolonged recovery period post umbilical cord blood transplant. But actually, many celebrities are saying that it is a possible, it is like ensuring your future. It is not so. So the myth is that it will help the father, grandfather, everyone in the family. It will cure all genetic disorders. But actually, private cord blood banking is not a biological insurance. Like I said, when the stem cells are defective, you cannot use the same stem cells for treating genetic conditions. So umbilical cord blood cannot be used for treating genetic conditions. So whenever there is a defect in the stem cell. And when do we actually recommend private cord blood banking? Say for example, in a family, the first child is affected with a genetic disorder which can be cured by bone marrow transplant, like thalassemia. Then if they are planning to have a second child, that child's cord blood can be preserved. Okay? And the second child, the fetus, can be tested for HLA, and we can preserve only if the baby is HLA matched. So it is recommended only when a first child is affected with a curable genetic disorder. So what do we do? In India, unfortunately, we don't have a very robust public cord blood banking. So public cord blood banking means everyone donates their cord blood, and whenever it is required by any other patients, it can be utilized. But all these banking which is promoted, they are all private cord blood banking, which means it can be utilized only for your own purpose. So private cord blood banking should not be encouraged, and all these advertisements are often misleading and exploit parents at their vulnerable period. So I'd like to have two case discussions just to understand how we went through transplant. I'll keep it very short. So first is a case of a metabolic disorder. So this is a baby R, who is a 2-year-old boy, who presented actually to the pediatrician with coarse facies. You can see that there is some amount of periorbital edema, the face appears a little abnormal, and he had lot of excessive body hair. So thankfully the pediatrician recognized that there is something abnormal with this child based on the clinical features. So this is a condition called mucopolysaccharidosis, where there is abnormal deposition of mucopolysaccharides. So his enzyme levels, so whenever we suspect mucopolysaccharidosis, there are a lot of subtypes. We check for each subtype based on the enzyme assay. So in this boy, he had a defective production of this enzyme, and it was this disorder was confirmed by mutation analysis. So basically, what is the storage disorders? So there is defective degradation of these mucopolysaccharides by lysosomal enzymes. And most of these disorders are autosomal recessive, except for this child who had a X-linked recessive disorder. So whenever the lysosomal enzymes are not produced, the waste products accumulate. Generally they accumulate in the liver, spleen, but they also accumulate in the brain, leading to visceromegaly and neurological disturbances. So they can have a multitude of presentation like coarse features, hepatosplenomegaly, short stature, and they can have intellectual disability. Sometimes they can have corneal clouding. So initially we check the excretion of these waste, that is glucosaminoglycans, and we can check the enzyme levels, and we can confirm with genetic testing. So for the treatment of mucopolysaccharides, all these storage disorders, what we can do is we can just give the child the defective enzyme. So that is called enzyme replacement therapy. It is available for certain types of storage disorders. But the problem is these enzyme replacement therapy, it is weekly IV infusion. It has to be continued for lifelong. And the cost for lifelong treatment for a child for enzyme replacement therapy will be somewhere around 100 crores, which is not at all imaginable. So how does bone marrow transplant helps? So whenever we do a bone marrow transplant, from the stem cells, the macrophages are produced. These macrophages, they give rise to the Kupffer cells. So these start producing the new enzymes, and these enzymes can even cross the blood-brain barrier, and they can even reverse the neurological manifestations. Whereas enzyme replacement therapy, the enzyme does not cross the blood-brain barrier. So neurological manifestations are not reversed with enzyme replacement therapy. So a bone marrow transplant is a one-time cost between 8 to 15 lakhs depending on the type of donor, and once it is successful, you have lifelong enzyme production. So here, this child comes under this group of disorders called metabolic disorders. So similarly, we went ahead. So we have selected the patient, the child's baseline workup, MRI brain, everything was done. This child did not have any neurological manifestations. Now for the donor selection, this child had a sibling, but unfortunately she was not matched. Next, what we did an unrelated donor search. So like I said, we have this registry, we give the HLA report to the registry, they will do a computer-based search. So this is how we do the computer-based search. This is how we get the report. This is 2 genes for each locus. So fortunately for this child, we had almost 356 donors. Usually we get at maybe 1 or 2 donors all over India. This was a rare scenario. We got 350 donors. So how do we select who is the best donor among these 350 donors? Next, we go into the sex of the patient. Generally, we prefer same sex. So this is a boy, we prefer a male donor. Next, we go into the blood group. So we prefer a blood group match. If not, we go for a blood group mismatch donor also. And then we check into certain other parameters. So one donor was chosen. He was in Hyderabad. So this again we confirmed this HLA typing, and his stem cells were collected in Hyderabad. So the donor need not travel to the place, to Coimbatore, to do this transplant. So the stem cells will be collected in his own native place. It will be airlifted. We receive the stem cells. If we are going to use it within 24 hours, we can just store it in fridge. If not, we can store it in a deep freezer with something called as a DMSO, as a preservative. So we can cryopreserve it if we need to use it at a later date. So before that, what we did was, in the rare scenario that the donor meets with an accident or something, he is not able to donate, we have given the chemotherapy. Then the child will not recover from the chemotherapy. He will go into irreversible aplasia of the bone marrow. So that is why before the bone marrow transplant, in cases of unrelated donor transplant, as a backup, we take the patient's own stem cells, so that at least we can recover the bone marrow in the rare scenario where the donor is not able to give the stem cells. So this is called a backup collection. So this is the patient who is undergoing the stem cell pheresis, and this boy had a femoral catheter. From that we collected the stem cells. This was preserved, but fortunately here we had the stem cells of the donor, so we didn't use his own stem cells. So we gave conditioning chemotherapy. So we give alkylating agents, we give serotherapy, and so the stem cell infusion, like I said, this blood bag is just hung and it is connected to the patient. This is our staff nurse. This is the child with the mother. So he's just receiving the stem cell infusion. So he had a few complications post-transplant, like we give prophylaxis to prevent graft versus host disease. These drugs, usually we use cyclosporin or tacrolimus. This drug caused a hypertensive emergency in this child. So he had a BP of 170, 100, and he started having blurring of vision and headache. So we had to manage the hypertensive emergency. And he had neutropenia. He recovered from all that. So generally 2 weeks, that is 2 weeks post the date of infusion, we call day plus 14. So day plus 13, the neutrophils started to come up, and day plus 14, the platelets started to come up. And he was discharged on 16th day post-transplant with oral medications. Post-transplant, he developed some skin rashes later on. So this is likely skin graft versus host disease. So if it is limited, we can manage with topical immunosuppressants, or we have to give steroids. So this boy is doing well on limited steroids, which is being tapered off. And the success of the transplant is defined by enzyme production. So this is the enzyme assay pre-transplant, where you can see the reference range is 15 to 57. The patient had only 0.6. This is post-transplant, where we can see that the enzyme levels are normal. So basically the new stem cells have started producing macrophages, which have started producing the required enzyme in this child. So thereby, in this child, this bone marrow transplant was a success. So they are from Oman. They are planning to leave back to Oman. Second is a case of immunodeficiency. So this child presented at 11 months of age. So he is a third born to third degree consanguineous parents. He presented with hemolytic anemia, and he had a long course of recurrent infections. He had recurrent pneumonia, gastroenteritis, CMV pneumonia, influenza, parainfluenza infections. So at the same time, he also had immune hemolytic anemia. So this is a danger, because for immune hemolytic anemia, we have to give immunosuppressants. At the same time, he also has immunodeficiency. It is like poverty in plenty. One side he has autoimmunity, one side he has immunodeficiency. So the treatment which we give for autoimmune manifestation like autoimmune anemia itself will lead to immunodeficiency. So we had to balance both, but unfortunately we were not able to. He had infections. So we were giving steroids, mycophenolate, then we were giving sirolimus. All these are immunosuppressants. So this boy, initial evaluation of the immunodeficiency was all negative. So we went ahead with a genetic diagnosis which revealed a rare type of immunodeficiency called LRBA deficiency. So from 11 months of age till 4 years of age, he had multiple infections. So you can see that he has a bad lungs. So during infections, he almost has a bilateral diffuse lung involvement with pneumonia. So many microorganisms were isolated at many stages. So this boy at 4.5 years old of age, he developed headache with neck stiffness, no neurological deficit. Imaging revealed multiple T2 white hyperintensities in bilateral cerebral as well as cerebellar hemispheres. Now we went ahead and we did all the microbiological workup. So the initial CSF revealed a lymphocyte predominant meningitis, but all the microbiological workup, including TB workup, gene expert, everything was negative. So we started anyway, based on the clinical picture, we started on empirical ATT. The child responded. He was also started on steroids. Now since he was having a spiraling course, so he was having recurrent infections, he was not gaining weight, he was not doing well basically, he was having a lung disease. So what we wanted to do was, this child we wanted to make his immunity recover by giving new stem cells. So you can see this group of disorder called immunodeficiency, where there is T cell defect, bone marrow transplant helps. So what we did, usually what we do, we first check the HLA typing of the child as well as his brother who was 16 years old. So he was a perfect 10 by 10 HLA match. So we chose him as a donor. Similar to the previous patient, we collected stem cells by pheresis machine. And this boy, he received chemotherapy before the stem cell infusion. And then we gave the stem cells just like any other stem cell product. And this boy started having blood production by 2 weeks. So generally, how do we check whether the cells post bone marrow transplant is from the recipient or the donor? So we do something called as a chimerism test. So it will tell us exactly what percentage of the blood cells are from the donor. So that is what we do, called as a donor chimerism. So anything more than 95% is acceptable, which means of the 100 nucleated cells in the recipient, 95 cells are from the donor. So I obtained permission for these images. So this is the boy. So this is a bone marrow transplant unit. We generally have a HEPA filter room. This is a UV light pass box. Only through this, all the products will be sent to the bone marrow transplant room. Once he started recovering, we took him out of the room, and he's actually playing with the staff nurses. Fortunately, he didn't have any infections during his neutropenic period. He's recovered well. He's almost 2 months post-transplant now, and he doesn't have any infections. He continues to be on immunosuppression as well as anti-tubercular therapy. So these two conditions, one is metabolic disorders, one is immunodeficiency, 2 cases we discussed. Similarly, we can do transplant in hemoglobinopathies where these children will be transfusion independent post-transplant. And similarly, in aplastic anemia, bone marrow failure, the new stem cells will start to produce all the blood lineages and thereby the bone marrow recovers. So, on summary, I'd like to say hematopoietic stem cell transplant is the standard of cure in many benign conditions, especially in children. So, previously some disorders were thought to be incurable, like storage disorders, because the treatment of enzyme replacement is not available to many, but now we have bone marrow transplant. And we have increasing donor availability. Like I said, even the parents, though they are half matched, they can be used as a donors. Supportive care is the key. So caring of these children during the neutropenic period and post-transplant also. They are prone to a lot of viral reactivations post-transplant. So supportive care is the key. And stem cells, usually they are collected by pheresis, which is an outpatient procedure. The donor has almost no risk. Stem cell infusion is just like any other blood transfusion. And private cord blood banking has very limited use, so it is not usually recommended. And we can all register to be stem cell donor. Any healthy adult can be a stem cell donor. So you just have to log into Datri website. They will send you a buccal swab. We just have to swab it and send it back to them. So when we get the opportunity, we can be a donor to any of these affected children. Thank you.
Thank you, ma'am.
Hello. Hello.
Thank you, ma'am. Actually, Dr. Ajita is a practicing hemato-oncologist at GKNM Hospital, and when Sanofi approached us regarding this monthly meet, and they were telling that madam will be coming and giving us a talk about this stem cell transplant, I was just wondering what to do, like நம்ம general practitioners how this is going to be helpful. And regarding genes numbers na எனக்கு முன்னாடியே தலை சுத்திரும். மேடம் கிட்ட கேட்டேன், மேடம் இது ரொம்ப எங்களுக்கு புரியுற மாதிரி சொல்லுங்க, otherwise it will be like it will not be useful for all the general practitioners. And I think madam has done a very good job. My questions will be, madam, how long these kids has to be on immunosuppressant, one, and regarding donors, is there any age limit for the donors?
So regarding immunosuppression, generally it depends on for what condition we are doing transplant. So for malignancies like leukemia, when we do an allogenic transplant, what we want is the graft to react against the host leukemia cells. So we want graft versus leukemia effect. So when we give immunosuppression, we are actually suppressing the immune system of the donor. So we want to wean off immunosuppression early so that there can be some amount of immune reaction. So we generally tend to wean off immunosuppression by 3 months to 6 months at the earliest. Whereas in benign conditions, we don't want graft versus host disease. So that is something which is not required. So the recommendation is to give immunosuppression for at least 1 year. So post 1 year, if the child does not have any graft versus host disease, he can be off immunosuppression. He doesn't need to be on any medications post that period. So generally the period of follow-up is 1 year. Initially the follow-up will be 2 weekly once up to 3 months. Then it will be monthly once depending on what the child has, any complications. So 1 year is the time period. And regarding the age limit of the donor, generally as we age beyond 60-65 years, our bone marrow stem cell reserve is going to be less. So the upper limit is going to be 65 years, but we generally prefer up to 60 years, 18 to 60 years. But if it is going to be a sibling, any age, we can do a stem cell collection. Even if it is going to be a 1-year child or a 2-year child, if it is going to be a family member, we can collect at any age. I mean, younger age is not a cutoff. Unrelated donor, it is going to be 18 to 60 like blood donations.
Any questions in the floor? If there are no questions, I'll kindly call upon Dr. Ayyavu sir to honor our guest speaker. I now call upon Dr. Ram Prabhagar. He is a consultant emergency physician practicing at Lotus Hospital. He will be talking about all day-to-day medical emergencies that we face in our general practice.
So, good evening all. I thank Erode IMA and especially my close friend Dr. Parthiban for giving me this opportunity to address you all in this gathering of senior physicians in Erode. This is my first address in Erode IMA. So today the topic given to me was about medical emergencies in general practice. So before going into this talk, I think you have been provided with a small quiz of 10 questions with your updation forms, along with your updation forms. Can you please submit those forms before we go into it? So it's going to be based on those, discussion should be based on those. So please submit your forms before going into it. So, any medical emergency in general practice is a nightmare for a practitioner. So, any patient collapsing in front of you, very sick patient during a general practice, during a late evening OPDs or in the morning OPDs is going to be a nightmare for most of us. So, we hesitate to address the initial management of this patient and rather send to the higher center at the most because of this medical legal issues and we are going to handle and the crowd we are going to handle later on if the patient collapses in front of you. So taking a step forward, we will have this ABCD approach to all your medical emergencies. So this will help you in aiding to address each and every system of the patient, and particularly in a patient who is very sick. So this ABCD approach was basically developed in trauma management in the US by the American Society of Surgeons. So where an orthopedic surgeon lost his entire family in a plane crash because the surgeons failed to address the primary problem of the patients. So that was an airway problem. So most of the time the most distracting wound will be distracting us and we'll try to manage those injuries rather than attending to the impending problem. So we have a stepwise management here. So we have 5 clinical scenarios. There are a lot of medical emergencies happening around. We have 5 clinical scenarios where you going to interact with me and interpret and managing the patient. So before going into the scenarios, I will just tell you about these ABCDs of management. A is airway evaluation. So any patient who is live and is talking to you in your OPD, so first thing you have to see is airway, because your airway is the prime functionality which will help the patient to approach you. So if the patient's airway is able, most of the time he will be able to address his problem. So if the patient is able to talk clearly to you, his airway is patent. The patient is able to complete one sentence, then his airway holds good. And we have to look for any signs of stridor. The patient is able to breathe on his own properly. Is there any signs of hoarseness of voice? So all these things will help you evaluate your airway. So if the patient's airway is not fine, the patient is snoring in front of you, is not able to talk, is clenching his throat, then you have to probably manage his airway. The airway could be blocked or obstructed due to secretions, particularly geriatric patients. When they present to you in a collapsed state, most of the time their airway will be obstructed due to secretions. In this case, you have to do these simple maneuvers to open their airway. So opening their airway will help them to manage the rest of the problems. So we have to do a head tilt, chin lift, jaw thrust, try to suction out most of the products, particularly your oral secretions, and then administer O2. These are the basic procedures you do in a bedside, in a clinic, to address the airway of the patient. So to open the airway, so you can use your oropharyngeal airway or a Goodell's airway, put inside, suction out the secretions. If at all it's a trauma patient, suction out the blood from the throat. And you can use this simple device in your OPD if at all you have an emergency to open your airway. So this is a laryngeal mask airway where you need not have your laryngoscope to do an intubation. You can simply insert the laryngeal mask airway directly into the throat of the patient, and you can use your ambu bag to ventilate the patient till help arrives. This is the maneuver you can use. So you hold the LMA with like a pen and insert it through the palate. up to the larynx. So the LMA parts are, this is the oral end where you connect it to your bag and mask. This is your bite block area, and this is the supraglottic area. So this is the cuff. So you have to insert the airway and then up to the bite block area. That is, bite block area should be between your teeth, and then start bagging it after inflating with about 40 to 50 ml of air using the syringe. So maintaining a definite airway in OPD is always difficult, but still if you have these equipments with you, you can well and good intubate the patient if the patient's airway is collapsed, because if the patient's airway is not fine, you are not going to take care of him. So coming to breathing, so what are going to check is inspection of your large airways, that is your trachea. So check for the position of trachea, so whether the patient's trachea is in midline or pushed or pulled to one side. Look for the chest wall symmetry and movement. If the chest wall is not moving properly, then probably there is a pathology on the side which is involved. And confirm your inspectory findings with palpation and auscultation. Look for a saturation and respiratory rate, and look for accessory muscle use, because the accessory muscle use will tell you about the work of breathing. So this accessory muscle use will help you find out whether the patient is hypoventilating. If the patient's accessory muscle use is very high, the patient is probably in a very dire respiratory distress. So in this you can see the asymmetrical chest wall movement. The left chest wall is not moving properly. The right chest wall is able to move well, but the left chest wall is not able to move properly. The trachea is in midline. So this is the way you have to look for the patient. The third thing is, you see, that is circulation assessment. In the circulation, you check for the heart rate, you check for the heart sounds, and then check for the pulse, look for the character and volume of the pulse, check for the capillary refill time. If the capillary refill time is delayed, the patient is in shock. Even if the BP is good, the patient is still in shock if the capillary refill time is not good. And ask for the patient's urine output. So patient, if has not passed urine in the last 24 hours, then patient is having very low end organ perfusion and he is in shock, even if the BP is adequate. So these are the vital markers to assess your circulation. So urine output, your blood pressure, and your capillary refill time. So the urine output is the best marker to assess your end organ perfusion. In adults, if it is more than 0.5 ml per kg per hour, and in pediatrics it is about 1 ml per kg per hour. So coming to the disability, check for the patient's ability to move. The patient is able to move. Check for the extremities, whether they are able to move all the extremities normally. If the patient is able to speak to you normally, check for the orientation, whether he is oriented to time, place and person, and check for the Glasgow Coma scale. If the Glasgow Coma scale is less than 7 on your presentation, patient's airway is going to collapse and patient needs an advanced airway at the earliest. So in that case, need to put either an oral pharyngeal airway or put an LMA and refer to the higher center if not an expert in managing his airway. And check for his pupils too. So lastly, you have to check for the exposure. So look for source of sepsis. If the patient is presenting to you with a low BP, check for wounds. There any evidence of cellulitis, ulcers, or there is any edema. Suppose the patient is got a cardiac patient is presents to you in shock, look for peripheral edema, and then the temperature. So these are the way you are going to assess the ABCDs of the patient. So based on this, we will apply these ABCDs into the scenarios and we will diagnose and intervene how to go on. So this is your first scenario. This is Mr. X has come to your OPD with chest pain and sweating. When you examine him, suddenly he becomes drowsy and unconscious. The patient is lying on the floor near your OPD. Hopefully this will not happen. The patient's heart rate is query and BP is query on your examination. This is one of the nightmare scenarios you are going to encounter. So how are you going to handle it? So what will be a first step in management of this situation? Obviously, yeah, it's obviously check the response of the patient, whether the patient is responding to your commands or not. So that's what you're going to do. And what is the recommended time duration to check for the central pulse? So usually check your carotid pulse when the patient is not responding to you. You check your central pulse not more than 10 seconds. And still if you are in doubt whether there is a pulse or not, you go ahead and start your chest compressions. So will you intubate the patient in cardiac arrest? in a routine OPD busy practice, you are going to intubate a patient in cardiac arrest? Are you? So that should not be your aim. It's actually establishing the circulation. Your bag and mask ventilation and opening your airway will be more than enough in most of the patients. So first step in managing this patient is checking the patient's response. So tap the patient's shoulder loudly and check the response. If at all, if it's not responding properly, the second most important step is calling for help. So ask for the ambulance or your intensivist team to arrive at the scene, or call for the your EMT services to attend this patient if at all the patient is going to crash. And then the third step is checking for the central pulse. If you are not going to get a central pulse, then the patient is definitely in cardiac arrest. So as per the latest guidelines, it is not ABCD in managing a cardiac arrest. When the patient is alive, it is ABCD evaluation. When the patient has collapsed in front of you and he is in cardiac arrest, then it is always your circulation comes first. So you have to establish circulation to your brain. So first thing is circulation, which can be established by giving chest compressions. And second thing is, after giving chest compressions, you give 2 rescue breaths and open the airway. And the last thing is your breathing part. So there is no pulse, so give chest compressions in the ratio of 30 compressions with 2 rescue breaths, about 100 to 110 compressions per minute with adequate recoiling. And then after every 30 compressions, you give 2 rescue breaths using your ambu bag by using head tilt chin lift maneuver. And then after every 5 cycles of CPR, you check for the central pulse. If at all there is a pulse, put the patient in a recovery position and reassess the patient every 2 minutes. So if you have the luxury of having a defibrillator or an AED with you, during the initial cardiac arrest phase, during the chest compressions, you can attach your paddles to the patient and assess for the rhythm. So if it is a shockable rhythm, that is your ventricular fibrillation or your pulseless ventricular tachycardia, you are going to shock the patient with the maximum energy using your defibrillation machine. If it is an asystole or a PEA, it's a non-shockable rhythm where you give epinephrine and continue your chest compressions till the help arrives or the pulse comes back. So this is your advanced life support system. You need not intubate the patient all the time. You can wait and keep your airway open till the advanced help arrives, or the better person to manage your airway will be your intensivist or anesthetist who will be on the way to take care of the patient once the basic life support is done for the patient. So whenever there is a cardiac arrest and you know what happened to the patient, suppose the patient gives a history of chest pain before your arrival, it's more likely to be an MI. So if the patient has come back from the cardiac arrest, then refer him to the center where it is PCI capable, because most post-cardiac arrest we need to do a PCI if there is a history of myocardial infarction at the earliest. So those patients who are recovered from cardiac arrest, we need to immediately transfer to a center equipped with PCI to enable adequate reperfusion strategy. So in other cases where if it is a toxin overdose, you have to give the antidote. Suppose if it is a CKD patient, most common cause would be your hyperkalemic cardiac arrest, where you can use your calcium gluconate and soda bicarbonate during your cardiac arrest. Suppose if it is a pulmonary embolism, need to thrombolize the patient during your cardiac arrest. So these all can be taken care by the advanced cardiac life support team. Before those teams arrive, you can give the basic life support to the patient in your OPD and stabilize his airway and get his circulation back. So this is about the first scene. Now coming to the second scenario, this is a 42-year-old female with retrosternal burning sensation radiating to the jaw and back for 1 hour. There are no known comorbidities for this patient. On the examination, the patient is conscious and oriented. She has got a pain scale of about 5/10. Heart rate is about 56 per minute. BP is 90/50. SATs are normal. Respiration is normal. This is her ECG. Can anyone interpret this ECG? This is an inferior wall MI. So there is ST elevation over the lead 2, 3 and AVF, and there is there is reciprocal changes over lead 1 and AVL. So this is primarily a infralateral STEMI which needs to be intervened at the most. We have to reperfuse her immediately. So the ECG findings are, as you said, it is inferior wall infralateral STEMI. So diagnosis, it's acute coronary syndrome. So what initial drugs are going to give if you are going to encounter this case in a general practice? Anybody? So it's going to be an OPD. So what will be thrombolizing the patient, sir? Okay. So before thrombolizing, what are the drugs you would prefer to give to this patient, sir? Pain relief. Very good, sir. As you said rightly, it's exactly, sir, as you said. So it's basically an inferior wall MI. So we have to rule out right ventricular involvement also for this patient. If this patient comes to you in hypotension or in a bradycardia, we have to have all the equipments with us to rightly manage the patient. We need to have a temporary pacemaker if at all. We need to at least have a transcutaneous pacing to manage this patient properly if at all the patient develops AV blocks. As sir exactly said, before giving antiplatelet therapy or thrombolytic therapy, we have to be equipped to manage this patient, because this patient might seem to be simple but can land up in a lot of problems. The patient can go for refractory cardiogenic shock. The patient can land up in right ventricular failure during the management, particularly during thrombolysis. So we should be adequately equipped to manage these things. So most of us fail to see this condition. When the patient presents to you with chest pain and an inferior wall MI, we tend to give inotropic support rather than initiating fluids for the patient. So I have seen many of the practitioners starting either dopamine or noradrenaline for the patient before sending to the higher center. So before giving fluids for the patient adequately. So if there is a right ventricular involvement, we have to take a right side ECG for this patient and then start giving fluids for this patient. We can give up to 1 liter judiciously for this patient, 1 to 2 liters of fluid for this patient, and then get the preload up and maintain the RV function, and then refer the patient to higher center. And for this patient, we need to avoid sorbitrate, that is nitroglycerin. In inferior wall MI, we should not give sorbitrate or nitroglycerin. Latest guideline says your sorbitrate or your nitroglycerin is not useful in managing patients who present with STEMI, ST elevation MI. So it is very rarely used by the cardiologist now during STEMI conditions in acute settings, because in stable angina this nitroglycerin has got effects, but in acute setting where there is a complete occlusion, this nitroglycerin has not got not that much role, but it can lead to a lot of problems for the patient. So the standard of therapy would be giving antiplatelets, oxygen for this patient, and then use morphine judiciously for this patient if he has severe chest pain. If the patient is in respiratory depression or is in early pulmonary edema, sometimes older theory says morphine will help in circulatory reducing the circulatory overload, but nowadays we don't prefer morphine when there is a pulmonary edema or a respiratory depression, because it can aggravate the situation. So morphine can be still used, but it should be used with caution for these kind of patients. So this is about managing your acute coronary syndrome. And third one is a 44-year-old male with asthma who comes to your OPD with sudden onset of shortness of breath. So he is not able to complete one full sentence. He is quite restless. His heart rate is about 135 per minute. His BP is 100/60. SATs 80% room air. Respiratory rate is about 40 per minute. There is evidence of clubbing on examination. There is reduced air entry in both the lungs. There is indrawing of ribs. So this is increased work of breathing you can see in this patient. There is accessory muscle use. So what are the primary problems you are basically seeing with this patient? So airway he's got an airway problem because he's not able to complete one sentence. It could be an airway or a breathing problem. So he's got both airway and breathing problem. There is tachycardia, there is some amount of BP is holding good, but still he can land up in hypotension. He can have a airway, breathing and circulation problem. So what would be a diagnosis? So it's basically a acute life-threatening asthma exacerbation. Sorry, sir? Yeah, it's definitely chronic obstructive pulmonary disease with acute life-threatening exacerbation. So, is it a moderate severe asthma or a life-threatening asthma for this patient? So, which clinical points will favor in your diagnosis? So, whether it's a life-threatening asthma, this is an impending ticking time bomb in your OPD. This patient might collapse any time. See. Sorry, madam. BP is borderline. Patient is hypoxic. So, accessory muscles are in action. So, the work of breathing is very high, and this patient will require assisted ventilation at any time. The patient can require an NIV or a ventilation support. The patient can go in for narcosis, type 2 respiratory failure at any time because of his increased work of breathing. So this patient cannot be managed with bronchodilators and nebulizers alone, and he might require assisted ventilation. So this clue would be your accessory muscle use. So your accessory muscle use, if the patient is cyanotic on presentation, he is very much in anxiety, is very restless to you on presentation, that indicates that patient has got profound hypoxia. Those patients will require concentrated oxygen therapy with assisted ventilation at that time, and you need to give intravenous steroids along with magnesium sulfate for those patients. So bronchodilators and nebulizers will not help for this patient. You need to have assisted ventilation. So these patients needs to be referred to center where it is adequately available. So your steps in initial management for this patient would be, so you have to give oxygen therapy, you have to give in a concentrated manner. You cannot give use NRBM mask. You cannot give 15 liters of O2 for this patient. So because he is a COPD patient or a bronchial asthma patient, he can have a impending type 2 failure, which can when given oxygen can lead to CO2 narcosis, and the patient can collapse to you. So you should give your oxygen using a Venturi preferably for this patient. So for treating life-threatening asthma, so the parameters would be, if the saturation is less than 92%, with any of this, the patient has got silent chest, the patient has got signs of poor respiratory effort, the patient is confused or agitated, and his peak expiratory flow rate is very low, then you have to consider life-threatening asthma, and this patient will require beta-2 agonist bronchodilator therapy with administration of steroids and assisted ventilation. Your main drug in your armamentarium would be your magnesium sulfate. So you can give in a dose of 50 mg per kg IV bolus over 15 to 20 minutes if you encounter such situations and you are very sure if it is going to be asthma. So this will be your fourth scenario. So 70-year-old female brought to your OPD with complaints of drowsiness. She had decreased oral intake, vomiting 2 episodes, decreased physical activity for the last 2 days, passed urine only once. She was drowsy but arousable, quite restless. Heart rate is about 110 per minute. BP is 90 by 50. SATs 93% room air. Respiratory rate 30 per minute. Her sugars of about 254 milligram per deciliter on arrival. So based on this scenario, what would be your initial working thing? So what will be your initial diagnosis? Very good, sir. It could be an acute kidney injury. So patient could be still dehydrated. She could be in hypovolemia because of decreased oral feeds and intake. So there can be a lot of working diagnosis for this patient, because patient is basically has got decreased response. She could be in altered mental status. Her respiratory rate is slightly higher than normal. Her BP is low. She is tachycardic. Her SATs are low. So first diagnosis should be sepsis. Any old age patient presenting without fever with these kind of symptoms, decreased activity, decreased oral intake, and decreased urinary output, altered mental status. Fever would be the last manifestation for most of these patients, particularly geriatric patients. So these are signs of sepsis. So whenever you have patients with these kind of constellation of symptoms, if the respiratory rate is more than 22 per minute, BP systolic is less than 100, and the altered mental status, is there any presence, then you have to think about high morbidity. So patient could have been in a severe sepsis or can land up in septic shock. So what are the markers used to measure end organ perfusion? See, this patient has got a problem with airway, can have a problem with airway later on, because the patient has got a saturation low. So respiratory rate is high probably because of sepsis, low blood pressure and low end organ perfusion. So she's got a problem with circulation also. So what would be the ideal marker for this patient to measure the end organ perfusion? So she had itself given a clue that she has passed urine only once in the last 24 hours. So definitely the patient has got decreased end organ perfusion and she is in septic shock. These patients should be hydrated adequately with right amount of crystalloids in your OPD and refer to higher center. So your first step would be administering fluids for this patient, because she is in septic shock. Her BP is 90 or 60. You can give crystallized either normal saline or your liquid lactate about 20 to 30 ml per kg bolus. You can start with 20 ml per kg bolus. If the patient is not responding to your initial bolus, then you can extend it up to 20 to 30 ml per kg maximum. So draw cultures as early as possible. The latest recommendation says it should be within 1.5 hours of evaluation of the patient, and then give broad spectrum antibiotics to the patient based on the source of sepsis you suspect, and start vasopressor simultaneously if indicated for this patient. If the patient is not responding to fluid therapy and is in profound shock, you can start your crystalloid bolus along with your noradrenaline support as early as possible for this patient. So your last scenario would be a 26-year-old male coming to your OPD with breathing difficulty, is unable to swallow or cough. There is numbness over the tongue, is profusely sweating and very anxious. He gives redness of face and itching, which subsided 2 hours after a seafood meal, which he has taken afternoon. So an examination is conscious but very anxious. There is some amount of hoarseness of voice. There is mild inspiratory stridor. Heart rate is about 120 per minute. BP is 90 over 60. Saturation is 96% room air. Respiratory rate is 28 per minute. Your cardiovascular and respiratory system examination is normal, and your skin seems to be normal for this patient. So this is basically an anaphylaxis, but anaphylaxis is not the right diagnosis for this patient. It is anaphylactic shock because the patient's BP has gone down. So the anaphylaxis management and anaphylactic shock management differs. So your diagnosis rightly would be anaphylactic shock. What would be a drug of choice and dosage? So as you rightly said, if it is anaphylaxis, we can give IM or subcutaneous adrenaline epinephrine, 1:1000 dilution you can give, and then your secondary drugs, your diphenhydramine or chlorpheniramine maleate with hydrocortisone you can give up to 600 milligram. But for this patient, rightly we have to give adrenaline IV because the patient is in shock. So most of the general practitioners hesitate to give adrenaline during the initial even if they make a diagnosis of anaphylaxis, they hesitate to give adrenaline at the first drug of choice. They used to give chlorpheniramine maleate, hydrocortisone, watch for a while, and then preferably if the patients even subside down, they don't give adrenaline. But there are higher instances where you can get refractory anaphylaxis and the patient can go for bronchospasm. So preferably your drug of choice in managing anaphylactic reaction should be adrenaline at the most. So it's severe anaphylaxis and anaphylactic shock, and you have to give adrenaline, preferably IV, 1 to 5 g IV bolus. Watch for the BP response and rest of the parameters, and if the patient is stable, you can stop the adrenaline dosage. If at all the patient has got continued reactions, you can give adrenaline IV infusion at the rate of about 1 to 5 mg per hour. So anaphylaxis can have varied presentations, because recently I had a young female patient in my ER. She came to our ER around 9:30. She had a seafood meal after 3 o'clock. She was quite okay. She didn't have any urticaria, itching. The patient, when she came into ER, she had nasal congestion, and she was very subjectively saying that she had breathlessness, and clinical examination was quite normal, and we were just very anxious why she is that much breathless, because she didn't have any signs of stridor. Patient was absolutely okay, but she still complained of breathlessness. The only clue which she gave was she had a seafood meal. So after a while, suddenly the patient started throwing seizures in our ER, and later we thought that it could be anaphylaxis, and the patient was given immediately IM adrenaline, and the symptoms subsided down. After some time, patient had profuse sweating, and we took an ECG. The ECG showed diffuse ST depression all over the precordial leads, and we confirmed it that the patient had a severe anaphylactic reaction, and sometimes anaphylactic reaction can lead to coronary vasospasm. So, and this patient recovered completely after giving adrenaline. So these patients doesn't require any coronary intervention for these kind of patients. Troponin levels were normal for this patient. Cardiologist was involved. Echo was normal. So anaphylaxis can have varied kind of presentations. It need not be urticaria, itching every time. So it can present with hives, swelling, warmth. Patient can even present with refractory coughing and sneezing to your ER or OPD at times. There can be diarrhea at times during presentation. Sometimes a patient can rarely throw seizures even in anaphylaxis. So the 4 steps you take in management of anaphylaxis is: first, you should be aware whether it could be an anaphylaxis or not. So look for signs and symptoms of allergy. Use only adrenaline if you have a strong suspicion of anaphylaxis. So when you use IV adrenaline, you will have a doubt how to use it, how much dilution you have to use it. You can mix it 1 ampule of adrenaline in 500 ml of NS, which will give you a dilution of about 1 mics per ml. So you can use this push dose of 5 to 10 ml in 2 to 5 minutes if the patient is in anaphylactic shock. If the patient is got refractory hypotension, you can use it at an infusion of 1 to 20 ml per minute. That is, will be equivalent to the dose of 1 to 20 mics per minute. So most of them will have a difficulty in handling the dosage of adrenaline. So while giving IV, so this should be the way it can be easily calculated and used in patients with anaphylactic shock. So nowadays, epinephrine auto-injectors are available for patients who suffer with refractory anaphylaxis, and you can prescribe safely these auto-injectors for this patient as outpatient device. Whenever the patient gets anaphylaxis, she can self-inject her epinephrine and get relieved of symptoms. So I think I given some justice to my topic for general practitioners. So if at all you have any questions, please feel free to ask.
Thank you, sir. Any questions from the floor?
It could be still anything we need to evaluate. So this is basically in OPD practice, if you encounter such constellation of symptoms, think about sepsis. That's what I was about to say from that scenario. So it could be anything. During evaluation, it could be an occult urinary sepsis for this patient because the sugars were high. Urinary tract infections, particularly in old age, can present with these kind of constellation of symptoms.
IV adrenaline, how long are you using IV adrenaline?
Sorry, sir?
IV adrenaline for anaphylaxis.
Yes, sir.
How long have you been using?
Sir, I have used for almost 3 to 4 patients with severe anaphylactic shocks.
How many years are you using?
How many years, sir?
When it has come into vogue?
Sir, this has been for a long time, sir. These guidelines have been there for a long time. Patient, if is in shock, we can give it as IV. We should give it as IV rather than giving it as IM and
Subcutaneous.
The rationale behind it is, if the patient is in shock, the absorption will in IM and subcutaneous will be low. That's the rationale behind it, sir.
Thank you.
If there are no more questions, I kindly call upon Dr. Thangavellu sir to honor our speaker. We have come to the end of the day, and I kindly call upon Dr. Arvind to give the vote of thanks.
Good evening. On behalf of Erode IMA, I thank Dr. Ajita and Ram Prakash for their wonderful presentation. Thank you, ma'am. And I thank all members for your participation. I thank our sponsors, Sanofi, for this sponsoring this meet. National anthem. I request everybody to please stand up for national anthem. I request